Welcome to the lecture for module number 3 for Medical Ethics Online during the summer of 2011. I'm, again, Eli Weber, your instructor. And today we are going to take a look at the question of informed consent to participate in medical research. And in particular, we're going to look at informed consent and how it relates to the value of autonomy that we've been sort of discussing in the first two, especially the first module. The goals of this lecture are first to specify the conditions for informed consent. We want to know exactly what has to be the case in order for a patient's agreeing to participate in a research project is going to count as informed consent and be morally acceptable. We're also going to talk about the concept of vulnerable populations, what they are, why they create concerns with regard to the obtaining of informed consent, and how we ought to approach interacting with vulnerable populations. And we're going to conclude by looking at these Jehovah's Witness blood transfusion type cases, such as the one outlined in the Savulescu and Momeyer reading that was assigned for this module. Although that case is dealing with informed consent in a medical treatment context, there is some applicability to research contexts. It makes a fairly significant point having to do with what the requirements of informed consent actually are. Most importantly, it suggests that in order to obtain truly informed consent, you have to do quite a bit more than just make sure that your patient or your research participant fully understands what the project would involve and the risks and that sort of thing. You also have to make sure that they have rational beliefs. So we'll talk a little bit about what that means and how that applies to research contexts. And for those of you who perhaps didn't notice, the Savulescu and Momeyer reading does have a reading guide. It's posted in the Module 3 folder under the Readings folder. That's not intended to be a replacement for the reading. It's intended to supplement it because that reading is somewhat difficult, and I think it could be fairly easy to get confused and get caught up in details that aren't maybe the most important for our purposes. Okay, so that's our plan. And the first thing that we need to do before getting into the specific details about when consent counts as informed, we need to first talk about why we should care about informed consent at all. And most people think that informed consent is essential to the protection of patient autonomy. Keep in mind, autonomy, there are a lot of ways that it can be defined, but it's roughly this idea that people have a right to self-determination. They have a right to be the authors of their own lives, to make free, fully informed, reasonable decisions about their medical care and whether they want to participate in a research project. And so, in the case of research, obtaining informed consent is a way to ensure that your participants' involvement in the research is free, uncoerced, and fully informed. You want to make sure that your patient knows what they're getting into, basically. You want to make sure that there's nothing morally or legally problematic about your recruitment of them into the study. There are all sorts of ways that consent can be obtained in a way that's maybe ethically or even legally problematic. So from a practical point of view, we want to avoid obtaining consent that isn't fully informed, that's not ethically and legally legitimate. And from a broader moral point of view, we want to respect and protect people's autonomy. And so the idea behind informed consent is that by ensuring that consent is fully informed and properly informed, we protect autonomy. Okay, let's talk a bit about the conditions for informed consent. And before I do that, I should say just a bit about when this process takes place and how it is typically approached. So before a research study is begun, and sometimes while it is going on for sort of longer studies where you have overlapping enrollments, someone, typically either the principal investigator or one of the research assistants, but in some cases it might be the patient's own doctor, which has its own worries, but someone affiliated with the study will present the opportunity to participate in the research project. That's typically what occurs. Occasionally, individuals will pursue participation. This happens frequently with cases of patients with terminal cancer. There are websites available where terminal cancer patients can acquire information about where experimental cancer drug studies are taking place, and it's a way of letting them know where they can go and try to get involved in some experimental drug research. Typically, these are patients for whom traditional treatments have failed, and so they're looking for sort of anything that might work for them. But that's not typical. Typical, what happens is either a doctor refers a patient to a researcher, or the doctor actually is the researcher, and they will discuss the project with the patient, talk about why they think the patient or the person, if it's not their patient, might be a good candidate, might be interested in participating. It's really important the way that it's framed, the way that it's described, because there are a number of things that patients have to understand, and so that's why understanding is one of the conditions for informed consent. Patients have to understand all sorts of things. First, they have to understand the potential risks associated with the project. They also have to understand the likelihood of those risks. In some cases, it's sort of an open question whether informed consent requires that you inform your research participant of all the risks that might occur, possible side effects, even those that are extremely rare. I mean, do you have to tell a research participant about a side effect that only occurred in 2 out of 1,000 participants? I mean, does that count as a potential risk, or does it not count as a potential risk in virtue of the low probability? That's an open question, but in general, we want patients to understand, or research participants to understand, the potential risks of participation. We also want them to know the possible benefits. For example, we don't want a participant in a phase 1 study, which is a study of toxicity, not of efficacy. So phase 1 studies do not test whether or not the drug is effective. It just measures toxicity. So it's important that if someone is participating in a phase 1 study, that they're not doing it because they think a benefit is likely, because they may not actually be receiving therapeutic levels of the drug. They may be receiving too much or not enough. And they need to understand the likelihood of the benefits. This is going to include also what patients should not expect. In some cases, treatments will give a patient improvement in symptoms, but it won't actually eliminate symptoms. And in a lot of cases, especially with experimental research that isn't strictly motivated by a medical need, the benefit is usually a benefit just to other people. There are often cases where the only real benefit that is going to come from participation in a research study is not actually going to be to the participant themselves, it's going to be to other individuals. They also need to understand the specific details of the treatment or procedure. Is it going to involve a special diet? Is it going to involve other medical procedures, having a lot of blood drawn? Is it going to involve physical discomfort of some kind, sleepiness, any side effects, as well as any specifics associated with the treatment or the procedure. When it's in a medical context, the individual, and this has more to do with treatment than experimentation. We're sort of talking about informed consent in general and then applying it to research contexts in this module. But in a treatment context, you want to talk about alternatives, including doing nothing. In some cases, participation in a research subject or in a research study is actually suggested as a possible treatment modality, and it's important to present to the patient the option of doing nothing if participation in the research study is presented as a treatment modality. And the reason, I should add, the reason that we're talking about informed consent generally is that oftentimes research and treatment can overlap in these cases. The medical service provider suddenly becomes the researcher when they start recruiting their own patients for studies that they are the principal investigator on. So the line between these is somewhat blurry, which is why I think it's okay to talk about informed consent generally, and then apply it specifically to these contexts. And then last, you want to make sure that the patient understands any other relevant considerations. Recovery time associated with the procedure, if it's a surgical procedure or something like that. Financial consequences as well. Is there going to be a loss of time at work? Is there going to be anything that's going to cost them additional expenditure as a result of side effects? Are they going to be paid? I mean, financial consequences could be positive as well. Some of that is going to overlap with risks and benefits, but the important thing is that anything that might be relevant to a decision about whether or not they want to participate should really be understood by the patient. But again, there's this concern, especially with regard to potential risks and possible benefits, there's a concern about how much information actually has to be communicated in order for consent to be considered fully informed. For example, in a phase 1 study, again, it's a study of toxicity, but that does not mean there will not be any benefit. It's possible that a phase 1 study might actually be highly beneficial for someone. You would want to make sure that, number one, someone is not participating because they think the benefit is likely, but it wouldn't be quite right either to tell them that there is no chance of benefit, because you don't actually know. So the question there, similar to the question about information and potential risks, is whether you should present that as a possible benefit in something like a phase 1 study. So even having very specific conditions like this, there's still lots of open questions about what has to be communicated to the patient. The second condition for informed consent is competence. Most of us already know what this word means, and it's pretty obvious why you would want someone to be competent before you would take their consent as an indicator that they actually want to participate in a research study. We don't usually allow psychologically unstable and mentally ill people to give informed consent. In medical treatment contexts, we typically assign a proxy to make decisions for them. Usually they have a guardian of some sort, either a family member or a legal appointed guardian. But in general, we want to make sure that the individual is psychologically stable. You don't want to ask people in extreme duress or who are sort of in bad emotional condition. You don't want to ask someone 5 minutes after you've told them that their cancer is terminal whether they want to participate in a experimental drug study. It's probably not a good idea, because they're probably going to say yes, and there's probably going to be a concern that their consent was not fully informed because they were emotionally not in the right frame of mind to make an informed decision. This one is probably rather obvious, but it bears mentioning. You want to make sure the individual is of a proper age. Children are typically not allowed to give consent to participate in research, because we tend to think that a child is not competent because they're not capable of fully understanding what they're agreeing to. So there's a way in which these conditions for informed consent are actually related. In this case, age is an indicator of competence, but what we really want them to be competent about is being able to understand what they're agreeing to, and we think in virtue of their age they're not competent. But that incompetence is framed in terms of not understanding relevant information. Children are a bit of a trick, however, because you might think that there is a big difference between a 5-year-old and a 15-year-old. And you might also worry that with very young children, we shouldn't just take their parents' word for it. The Willowbrook experiments that you were assigned to look over for this module are a good example of that. This is a case where parents agreed to enroll their severely mentally disabled children in a hepatitis wing at a institution. So this is a wing where children were being deliberately infected with hepatitis in order to test treatment on them. You might think that for a 10-year-old or an 8-year-old, you should actually ask them whether they're all right with it. That's typically what's done with children that are 8, 12, 14, and cases can be made for younger and younger children. For older and older children, moving up towards the age where they're considered fully competent adults, it's easier to make the case for them, the 16-year-old. But we've even seen cases where um, what the child is asked is not they're not asked to give consent. They're asked to sort of affirm or reject their will, the option to participate. So they have to, they'll be asked something simple like, do you want to participate in this study? Here's kind of what it is. And if they say yes, that's not sufficient for informed consent, but it is necessary. So we have to have that in place, but we have to have parental consent as well. And the idea there is that we don't want parents sort of consenting on their children's behalf to things that the children actually don't want to do, or that we think the children probably don't want to do. And it's important to note that in those cases, a failure to respond is not taken to be affirmation of willingness to participate. So age, again, is another factor in assessing competence. And finally, this is related to psychological stability, but you want someone who is adequately aware of reality. So people who are schizophrenic are obviously going to be out. People with severe dementia. It's important to distinguish these, though, because some people can be psychologically stable in certain respects, but not be adequately aware of reality. In other words, they may seem perfectly capable of making reasonable decisions. They just think that it's 1978 when it's not. And some people are more or less aware of reality, but psychologically unstable in other ways. So those are often related, but can come apart. And it's worth just kind of noting that those are both important considerations in assessing competence. All right, the last major category regarding conditions for informed consent, and for those of you who like to connect things up with the reading, this is roughly taken from the Robert Young piece. I know that piece talked principally about informed consent with regard to medical treatment, but we're talking generally about informed consent and then applying it to research context in this module. Okay, so the last condition for informed consent is absence of coercion. This is going to include things like not giving undue benefits or inappropriate compensation. You don't want to offer someone $1,000 to participate in a research study that's going to be involve really uncomfortable side effects, because the concern there is, at least for some people, that financial compensation is going to motivate them to agree to something that they otherwise would not agree to. Now, there are all sorts of ways that undue benefits might be understood. When you're dealing with research on prisoners, which we're going to talk about vulnerable populations in just a minute, and prisoners are an example of that, you might think that in some cases one of the selling points of participation in a research project for prisoners is that, well, you'll get slightly better medical care. You'll get medical care from this independent research project. They have their own facilities within the prison. You'll get all your medical care there, and as part of that provision, you participate in this research study. Typically, something is going to count as an undue benefit if it is sort of substantially more beneficial than what the person would receive otherwise. So the trouble with that with regard to prisoners is that even fairly insignificant benefits start to look inappropriate. So things as simple as, back in the 70s and 80s, before this stuff was heavily regulated, it was not uncommon to offer prisoners cigarettes and candy bars and things like that, which normally you wouldn't think that receiving a candy bar would be much of a coercive tool for a non-incarcerated person, but for someone in prison, that might be enough to override the legitimacy of their consent. We might have a reason to think that was coercive, and it's in virtue of the circumstances that they find themselves in. What would normally not be an undue benefit becomes one in that situation. But in general, we want to avoid coercing people by offering them excessive benefits or compensation that is in some sense inappropriate. Another good example is, this is not uncommon, psychology courses. I don't know if it happens here at Bowling Green. Perhaps it does. Hopefully it doesn't. But psychology professors have been known to make participation in their research study a condition of passing the course. You might think that is not so much an undue benefit or an inappropriate compensation. It would be inappropriate compensation if it was extra credit. And it would fall under the third bullet point as a threat of punishment or harm if you were told that you could not pass the course if you did not participate. So this is another way in which consent can be coerced, by providing people with what seems like a fairly mild benefit or a very sort of subtle negative consequence, but still inappropriate, still sufficient to coerce participation. Another source of coercion that should be avoided is we don't want a strong personal connection between a patient and the obtainer of consent. So suppose someone finds out that they have terminal cancer, and their own physician suggests to them that they might want to think about participating in an experimental drug trial. Now, it's likely that the individual is going to weigh this consideration more heavily. They're going to regard it as take it a little bit more seriously in virtue of it having been presented to them by their own physician, as opposed to receiving a letter in the mail from an anonymous researcher, someone they don't know, they've never heard of, or being approached by someone that they have no personal connection with. The concern is that close personal relationship can actually be coercive in some cases, causing people to take the the presentation of the option as an endorsement. So when your physician says, there is this drug trial, it might be a good fit for you, it's your doctor, you're perhaps more likely to take that as an endorsement of your participation, as a kind of recommendation. And you're more likely to agree to a study that you otherwise might not agree to. And finally, as I already mentioned, we don't want a threat of punishment or harm to either a patient or their loved ones. In the most obvious case, this is participate or I'll shoot you. Obviously, we don't want that. But the psychology class example is a more subtle version of the threat of punishment that might count as coercion and might undermine informed consent. And notice that in all these cases, the concern is just that for you to choose autonomously, for you to be making a free choice about your own life, you should do that without undue external influence. You should do it because you really want to participate in the research study, because either you care about helping other people down the road, or because you are willing to take the chance that it might benefit you, even though you understand that the chance of that is not very good. It shouldn't be because you're afraid that you're not going to pass Psychology 101, and it shouldn't be because the healthcare in your prison sucks and it's the only way that you're going to get treatment for some other problem that you have. We don't want these sorts of things. In those sorts of cases, we would say that the person's decision to choose is motivated not by what they value and care about, but by these external influences, and that is not informed consent. Okay, let's talk briefly about vulnerable populations. Now, vulnerable populations are basically any group of individuals, usually they have a characteristic in common, where we have some reason to think that they're not capable of giving informed consent. And there are two ways to understand a vulnerable population. One way of understanding a vulnerable population is that this is a group of people for whom informed consent is impossible. Some people think this about prisoners. So in virtue of the coercive environment in which they live, I mean, they're sort of constantly being pressured to act in a particular way. Their life is very much about trying to accrue fairly meager benefits and trying to avoid excessive punishments. At least while they're in prison, that's what their life tends to look like. There's a concern that that sort of environment makes it impossible for someone to make truly free choices, because they're always going to be moved by inappropriate influences. It's just impossible to avoid. Or you might take a different view. You might think that vulnerable populations are just cases of patients where we have to be extra careful. We need additional precautions. One way to handle the prisoner case, because one of the worries with prisoners is that any benefit is going to count as an undue benefit, because their opportunities to acquire benefits is so minimal, and that actually the chance to participate and break up the monotony of being incarcerated is itself a benefit. Just basically, prison is so boring that prisoners are willing to agree to participate in any research project just for something to do. And so the very possibility of participation counts as a benefit for them. One way, actually, I have a paper that I've written about this. If anyone is interested in looking at it, I can certainly email it to you, or if a lot of people are interested, I can post it. One way to potentially deal with this problem is to say that the only benefits that can be offered in order to see whether prisoners are being coerced by sort of prison-related elements is to take a sample of individuals who are not incarcerated and see if they would agree to participate. So you test whether the prison environment is coercing your prisoners to agree to participate in the research project by asking a group of non-prisoners and seeing if they would do it. Because chances are, if the non-prison population is willing to participate, then the prisoners would have been willing to participate whether they were in prison or not. So that's one way to deal with that. The other way to deal with it, and that is what's often done on research with prisoners, is you allow certain kinds of benefits, like the medical care stuff is typically allowed, but the cigarettes and candy bars thing is not allowed. So if your research study means that prisoners participating are going to get slightly better medical care, you allow that. You don't regard that as, even if that is a benefit beyond what would be received, it's acceptable because it's not inappropriate in the way that candy and cigarettes are. Okay, so prisoners are one example of a vulnerable population. Another, children, for obvious reasons. They're not really of age to make informed decisions about their lives. But as I mentioned, there are concerns associated with just granting the power of informed consent to children, or to the parents of these children. What's typically now required, and that comes out in the discussion about Willowbrook that you guys read for this module, is that not only do parents have to consent, but the study has to actually be beneficial to the children who are participating. So the only way that Willowbrook would have been allowed today is if we knew that the hepatitis drugs that were being tested were going to work. And it would need to also be done on children that already had hepatitis, not a population of children that are actually deliberately infected with hepatitis. That would also not be acceptable today. Again, there are concerns about allowing parents full control as far as giving consent on behalf of their children. So, and we've sort of already talked about the safeguards for that with regard to asking the children themselves whether they are interested in participating. The mentally ill, obviously we worry about whether they can give consent. And again, the mentally ill are probably the most obvious case where we would say, oh, they just are not capable of informed consent because they're not competent. However, there's a problem with individuals who are mentally ill but under treatment. I mean, if someone is a paranoid schizophrenic but their maintenance drugs are more or less controlling their symptoms, do we still regard them as incapable of giving informed consent? And a lot of people want to say, well, no. So long as their symptoms are under control, it's perfectly acceptable for someone in that state to give informed consent. Other people want to say, no, this is not acceptable. Their status as a mentally ill person renders them just incapable of giving informed consent. That's another sort of point of contention, whether the mentally ill can ever participate in research. And one of the concerns about this is a practical one. The reason this comes up is a practical concern. Prisoners and institutionalized mentally ill people are captive populations. It's very easy to control other relevant factors in your experiment. You can make sure that your people show up when they're supposed to. You can control their diet if you need to. You can keep track of them rather easily. That's harder to do when your research population is the public. Okay, extreme people living in extreme poverty is another example of a vulnerable population. This concern at present comes up more when we're talking about expanding research to international grounds. So in the United States, no one would ever agree to participate in a research study that had on a drug that had harmful side effects in exchange for $1 a day. However, in an extremely poor nation, that might be considered a coercive amount of money. So whereas in the US you might be able to pay your research participants a somewhat meager amount of money because it wouldn't be considered enough to coerce them, in cases where people live in extreme poverty, that would be a coercive amount of money. So there's a concern there that people in extreme poverty, even any kind of benefit, is going to be too much. It's going to lead to coercion, which is going to undermine informed consent. And finally, individuals who are terminally ill. The concern here is that these folks are going to be overly optimistic about the possibility of benefits, and so not weigh the possible risks appropriately. Your case study for this module deals with a case of a terminally ill individual and whether they are capable of giving informed consent. And the big question with vulnerable populations is really whether vulnerable populations are necessarily incapable of giving informed consent. So in other words, in virtue of being a member of a vulnerable population, are you just ruled out automatically from participation in research? Or does your status as a member of a vulnerable population just mean that those who are trying to obtain informed consent have to be more careful, that there are extra safeguards and precautions that have to be taken? And it's an open question what the answer to that is. So keep that in mind when you're approaching your case study. And if you think that the answer to this question is no, that vulnerable populations are capable of giving informed consent, and what we have to do is just be extra careful, and you're going to want to specify for different types of vulnerable populations exactly what needs to be done in order to ensure that their status as a member of a vulnerable population doesn't undermine their ability to give informed consent. Okay, let's talk briefly about the Jehovah's Witness blood transfusion case. Now, this case is described in the Savulescu and Momire article, and basically the setup is this. You're a emergency room doctor, patient comes in, patient is Jehovah's Witness. You discover that the patient needs a blood transfusion or they're going to die. Now, one of the rules or laws of being a Jehovah's Witness is that you cannot receive blood transfusions. They have very specific requirements about this. They draw it from a couple of biblical passages that are discussed in some detail by Savulescu and Momire. But the idea here is that it's within the Jehovah's Witnesses' autonomy right to refuse this blood transfusion. So the typical analysis is just that a patient's right to autonomy in this case includes a right to refuse the blood transfusion. It would be morally objectionable for a doctor to force the Jehovah's Witness to get a blood transfusion against their decision not to receive one. And the reason for this is that the disagreement with the Jehovah's Witnesses' decision is based on a difference of values. So it's not that the Jehovah's Witness doesn't understand relevant features of the treatment that's being suggested, it's just that what they care about is different. They care more about following the tenets of their religion than they do about surviving. Now, the Savulescu and Momire analysis is somewhat interesting because they suggest that respect for autonomy actually requires that the individual making the decision has rational beliefs. So it's not enough, say Savulescu and Momire, excuse me, it's not enough that the Jehovah's Witness understands the information. It's not enough that they're competent. It's not enough that they're not being coerced. Their beliefs have to actually be rational. So and what that means is that they have to be considered in light of all the relevant evidence. They have to be consistent with other beliefs, so you couldn't have a belief that directly contradicts another belief that you hold. That would count as that would be a case of irrational belief. And in the case of, and then they have to be responsive to the laws of logic, of validity and soundness that we talked about earlier. And so Savulescu and Momire suggest that the Jehovah's Witnesses' belief that basically God does not approve of blood transfusions, isn't what they call theoretically rational. And they say, for one thing, although they rely on biblical interpretation to support this belief, there are actually other areas in the Bible that contradict that, and that Jehovah's Witnesses ignoring those passages, so they're not considering all the relevant evidence. And then the other concern is just that they're operating with inconsistent beliefs, because typically Jehovah's Witnesses are remarkably thorough in considering all the textual evidence, and this is one case where they're actually failing to do that. So for that reason, Savaleski and Momire suggest that the physician should at least engage in some kind of rational deliberation with the Jehovah's Witness. Try to encourage them to evaluate this situation in light of all the relevant evidence, not just sort of blindly rely on the law that their religion prescribes, but to actually think critically about these other biblical passages, the other things that they believe, and it's the physician, if not the physician, then someone in an appropriate position to be able to have a conversation like this with the Jehovah's Witness, so someone who understands the relevant biblical passages and that sort of thing. That there's an obligation, as a component of respecting autonomy, to sort of press on this decision, not simply take it as an exercise of the Jehovah's Witnesses' autonomy. Okay, this has a couple, although this is a medical treatment case, it has a couple of implications for research ethics. It's typically thought that if someone refuses to participate in a research project, that's the end of the conversation. You know, if they are capable of giving informed consent because they're competent, all the conditions of informed consent are being met, and they just say no, then that's it. You're done. But it seems like the way this analysis of the Jehovah's Witness case goes, maybe researchers should actually press individuals a little bit and find out what their reasons are for refusing to participate. Find out if their refusal is based on irrational reasons. Maybe even try to help them to, I shouldn't say convince them to participate, but help them to form rational beliefs and then reevaluate their decision. It also maybe means that when individuals agree to participate in research, we should do the same sort of thing. We should ask them why they're agreeing. We should maybe investigate whether what they are deciding is consistent with other beliefs that they hold, whether they're considering all the relevant evidence. So if a patient agrees to participate in a research project, and suppose it's a terminally ill patient, and her decision is based on thinking that the 10% chance that she's going to see an improvement in her condition makes it worth it to risk the 50% chance that she's going to experience painful and uncomfortable side effects. And then suppose you find out that in other contexts, she thinks that 10% is a pretty low percentage, it makes something fairly unlikely, and that she thinks 50%, a 50% chance of something occurring is quite high. Well, that would suggest that what she thinks about these percentages and these likelihoods in general is not reflected in her decision to participate in a research project based on only a 10% chance of benefit. This would be a case where, on a basis of irrational beliefs, you would actually want to reject this person as a participant in your research study, even if all the conditions for informed consent have otherwise been met. The most important thing with regard to this Jehovah's Witness case is that it suggests that the burden on a researcher who's trying to obtain informed consent is actually much greater than previously thought. It is not enough, according to Savaleski and Momire, to simply make sure that your patient or your research participant actually understands what they're getting into in terms of risks and benefits and details of the procedure, and it's also not enough to simply make sure that they're competent and eliminate coercion. You have to also make sure that they're deliberating in the right way, that they're really taking account of all the relevant evidence, that their decision is consistent with other things that they believe that might be relevant. So you have to do a much more thorough accounting of their agency, of their decision-making process. And you have to decide whether this decision is really reflective of rational decision making. And that means a lot more than just what the conditions for informed consent suggest. Another implication of this case that's worth noting is just that it's really a problem to distinguish between beliefs that are clearly rational, beliefs that are clearly irrational, and beliefs that are indicators of incompetence. I mean, if I believe that Barney the dinosaur is the current president of the United States, that the Cleveland Browns are the best team in the NFL, and that I'm 6'8", tall, dark, and handsome, then probably I'm just incompetent. I'm not just irrational. According to Savulescu and Momeyer, the Jehovah's Witness is irrational. But there are other beliefs that are associated with more mainstream religions, for example, that I think would count as rational, according to Savulescu and Momeyer, but that other people might say are clearly not rational. If you're inclined towards a scientific perspective, you might think that any decision that's based on a strong belief in God is just an irrational belief. But someone who is inclined towards a belief in God is not going to feel that way. So there's this huge problem about if part of what we have to assess in assessing evaluating informed consent is evaluating whether a choice is made based on rational beliefs, we need some standard by which we decide whether a belief counts as rational. And there's going to be a good deal of disagreement about what that standard is. So this is a huge implication that's highly problematic for the researcher, for our ability to actually obtain informed consent. All right, what's the bottom line? The bottom line here is just that informed consent to participate in research requires three components: understanding, competence, and freedom from coercion. And we've talked a little bit about what those requirements involve, the different dimensions that are involved, and the way that that can actually become complicated. Secondly, it's an open question how we should deal with members of vulnerable populations. Are they necessarily incapable of giving informed consent, or is their status as a member of a vulnerable population simply a warning sign to be extra careful in dealing with them? And if it's a sign to be extra careful, what do we need to do in order to make sure that their consent is fully informed despite their status as a vulnerable population member? Finally, depending on how we understand the requirements for informed consent, the burden that it places on researchers is going to range from fairly reasonable to what I would say is nearly impossible. The Savulescu and Momeyer suggestion that physicians and medical researchers should not only make sure that their patients understand what they're agreeing to, but that their decision to participate is based on rational beliefs is an incredibly high standard that, even if it could be met, might be impractical. Which suggests that if Savulescu and Momeyer are right, then there's a kind of practical impossibility associated with acquiring informed consent, which is that even if it is theoretically possible, even if it can be done, from the standpoint of actually doing research, it's too difficult to do. It's either too time consuming, or something that just cannot be achieved in the kind of relationships that are typically associated with obtaining informed consent.